Hello, my name is Kaitlin Baker, and I am a student nurse on the second floor of Glacier Hills Rehab Center. I am going to present a patient to you now. Patient is a 13-year-old unmarried Caucasian male with the initials BT. He has no former occupation and attends classes in a severely multiply impaired classroom at a school for special needs. His usual source of medical care is the DeVos Children's Hospital. Patient was admitted to the DeVos Children's Hospital on July 29, 2015 with the chief complaint of abdominal pain. Patient was initially seen 5 days previous due to abdominal pain, but was released due to lack of abnormal findings. Since the patient is severely autistic and nonverbal, his mother initially observed his body language and concluded the patient had intense abdominal pain in the suprapubic region of his abdomen. Because the patient is nonverbal, the characteristic of the patient's pain could not be accurately described, and the hospital's staff proceeded to assess the patient based on body language. Pharmacological interventions included the administration of Tylenol and Zofran to the patient orally. Non-pharmacological interventions included an abdominal assessment and ultrasound examination of his abdomen. The patient was previously hospitalized approximately 2 years previous with the diagnosis of chronic constipation. The patient's large intestine wraps superior to his liver and lacks character. As a result, patient's large intestine exhibits poor peristaltic motion. To combat the chronic constipation and resulting malnutrition, the patient received a gastrostomy tube to aid in his feedings and eructation in the years previous. Aggravating factors of the current episode included eating, drinking, and activity. Alleviating factors included lying down, extra burping regimens via the gastrostomy tube, and the administration of Zofran. Precipitating factors of the episode include the abdominal adhesions, the abnormal anatomy concerning the large intestine, and the lack of peristalsis. Additionally, while in the hospital, it was found that the patient had a very full bladder and refused to or could not urinate. A urethral catheterization resulted. Patient is currently home and happy and with his family. He continues to experience approximately 3 to 4 flares of nausea per week. However, his severe pain is seemingly gone. Vitals: blood pressure 110/68, pulse 82, respiratory rate 14, temperature 98.6. However, it is important to note the patient lacks a fever mechanism. O2 saturation while in the hospital was in the mid-80s. Health history: patient was born with the following defects: bilateral cleft lip and palate, tetralogy of Fallot, Horner syndrome, anoxic ischemic brain which led to brain damage, autism, chronic constipation, hydronephrosis at birth and again recently, although the mother did not specify which kidney was involved, and patient is currently up to date on all his immunizations. He did require extra titers, however, because his body would not respond to the initial ones. Patient's only known allergy is to septin, which causes emesis. Patient's surgical history includes the following: closed heart surgery at 5 weeks, open heart surgery at 15 months for tetralogy repair, open heart surgery to replace the pulmonary valve at 12 years old, approximately 2 heart catheterizations, however an exact date is unknown, 3 cranial reconstruction surgeries, 1 for the cleft lip, 1 for the cleft palate, and 1 premaxillary revision, several ear tube surgeries, age not specified, 1 tear duct surgery, percutaneous endoscopic gastrostomy at 11 to 12 years old, Nissen fundoplication to prevent emesis, which patient often engaged in for sensory stimulation. Medications: patient takes numerous medications for his heart, including digoxin, baby aspirin, and carvedilol taken twice orally per day. For behavior, patient takes guanfacine. He also takes sertraline and risperidone via his G-tube. For reflux, patient takes Prevacid orally in the mornings. For constipation, patient takes 17 grams of polyethylene glycol orally every morning. He takes 9 milligrams melatonin and 18 milliliters hydroxyzine orally every night to help him sleep. Finally, patient takes 3.5 teaspoons of the antibiotic sulfamethoxazole orally before bed. Functional assessment: patient's mother denies drug and alcohol consumption, and the patient does not smoke. In order to maintain adequate nutrition, he receives 6 cans of Pediasure, 1.5 calorie with fiber, and 36 ounces of water every day through his gastrostomy tube. Any food he ingests on his own is additional. Patient does not consume caffeine. Patient remains active by walking and using the therapy swing installed in his house daily. The therapy swings help him fulfill some of the many sensory needs seen in children with autism. He does not use any safety devices. Patient's sleep habits include going to bed at 9 p.m. and waking up at 7:30 every morning with an occasional nap. Psychosocial. Patient's family share responsibility in taking care of the patient. He has 2 older sisters and 1 older brother. Patient has good relationships with all his siblings and both parents. However, he goes to his mother when he is in distress. Additionally, patient has caretakers come in on days he is not in school and in the evenings. These caretakers aid in feedings, diaper changes, and medication administration. According to his mother, these caretakers have become part of their family as well. Stressors include car rides to places he does not want to go and being in the hospital. He copes by throwing fits or distracting himself. Patient's mother denies any environmental hazards. The patient's family identify themselves as Protestant Christians. They attend church weekly. However, mother claims that the patient cannot attend because he often has difficult outbursts in church and cannot sit still for the full hour. Educational level. The patient attends a school for special needs children. He is in the severely multiply impaired, cognitively impaired classroom. Patient's mother claims he enjoys school. Patterns of care. Patient has regular patterns of care, including nightly toothbrushings and showers. He also has a burping regimen 4 to 5 times daily with his gastrostomy tube. Patient sees various specialists throughout the year. Some doctors he sees monthly, while others only annually. Family history. Patient's family history includes type 2 diabetes in his paternal grandfather and 2 of his paternal aunts, heart disease in his paternal grandfather, hypertension in both his maternal and paternal grandmothers, and prostate cancer in his maternal grandfather. Review of systems. System 1, abdominal. Given the patient's reported abdominal pain and perpetual state of constipation, it is important to assess the abdomen for pain and abnormalities. According to the patient's mother, since the last episode, patient has less interest in eating and drinking and has lost approximately 5 pounds. Since patient receives Miralax every day, his stools are typically loose. Other than his pain subsiding, patient's mother claims nothing has changed since his trip to the hospital. She denies history of abdominal infection and claims that neither stress nor a particular type of food seems to contribute to his constipation. Although the patient gets nausea a few times a week, the patient does not seem to experience excessive bloating. Upon examination, patient's abdomen was smooth, rounded, and symmetrical. No observable masses, surface motion, lesions, or scars were present. The gastrostomy tube site was noted on the left lateral portion of the patient's anterior abdomen. No vascular sounds were auscultated in the aortic, renal, iliac, and femoral arteries. It was noted, however, that during auscultation of all 4 quadrants, few bowel sounds were heard. Light and deep palpation of all 4 quadrants revealed no pain. A light aortic pulse was felt. Patient also revealed negative iliopsoas, obturator, and rebound tests. System 2, genitourinary. Patient's problems urinating and need for urethral catheterization call for a genitourinary assessment. Patient's mother claims he holds his bladder for extended periods of time before flooding his diapers when he finally goes. Patient's urinary habits have not changed since the episode at the hospital, and because the patient is nonverbal, patient's mother is unsure whether or not he is able to control when he urinates, although he does seem to have some form of control. History of past kidney ailments include the diagnosis of hydronephrosis or swollen kidney at birth and again during the recent visit to the hospital. No changes in the quality of urine have been noted, and patient has no history of urinary tract infections. Examination of the patient in supine position revealed normal color, symmetry, and hydration of skin. No abnormal distensions, scales, masses, or indentations or scars were observed. Once again, the gastrostomy tube on the left lateral anterior side was noted. Auscultation of the left and right renal arteries revealed no bruits. Inspection of the costovertebral angles and flanks revealed normal color and symmetry. No discomfort was observed with palpation over the costovertebral angle. Due to lack of experience and supervision, I did not attempt to palpate the right or left kidneys for risk of tissue damage and discomfort to the patient. Palpation of the bladder revealed normal symmetry, location, and size. Patient did not display signs of discomfort or pain with palpation. Pertinent System 1. Cardiac. Patient has had multiple heart surgeries to repair his tetralogy of Fallot from birth. According to a 2015 article from the American Journal of Nursing, long-term issues after tetralogy of Fallot repair and surgery includes pulmonic valve regurgitation, ventricular tachycardia, and aortic dilation. The article states that all patients should undergo regular screenings to check for abnormalities every 2 to 3 years. Given these long-term risks associated with tetralogy of Fallot repair and the patient's history of heart surgery, it is important to perform a regular cardiac assessment to know any abnormalities that would indicate the complications mentioned. Pertinent System 2. Respiratory. According to a 2014 article published in the Elsevier Journal, a common complication of tetralogy of Fallot repair includes pulmonic regurgitation. Symptoms include shortness of breath on exertion and cyanotic skin. Given the patient's history of heart defects, it is important to assess the respiratory system to find any linkages between the heart defects and abnormal lung function and take necessary measurements to prevent aggravation of the complication if present.